I'm Dr. Maureen Whelihan, and I'm a practicing gynecologist. I'm a medical doctor and a fellow of the American College of OBGYN. While I spend still 80% of my day practicing gynecology, it is impossible to avoid the questions that come up about sexual problems and sexual function. And so it's very important that we have an open dialogue with our patients about their sexual problems or sexual concerns. Sex and sexual health are important to women across their life cycle. It's an important component of both emotional and physical intimacy throughout the lifespan. For women, physical intimacy is a means to achieve emotional intimacy, and this is an important need. I call on my healthcare providers and peers to take responsibility for managing the sexual health of their patients. And I hope that by having this discussion today, that I can give you some ideas on how to begin that conversation. I always tell my colleagues that they have no idea who is sexually active in their practice, if they were to guess. I'm pretty open and knowledgeable about this, but I often get a smile when I hear a good story in the office. So when we look at this slide, it's talking about who reports being sexually active, and that could be oral or vaginal or anal intercourse in the past 3 months. And you can see that in the graph, it's different age groups. So no surprise that in the younger age groups, the percentage is higher in these U.S. women that are sexually active. I would guess that that number is a little bit higher, but depending on when they entered the survey, there was an influence. As you see in the 50 to 59 group, that number drops. And I think there are several influences here. Certainly the length of the marriage and being with your partner in a relationship for 30 years can be a problem, or at least contribute to sexual desire. But also there are hormonal influences and vaginal dryness that starts developing with menopause, and things that we can actually do to help these women. When we look at the 60 to 94-year-old group, I smile because I see 20%. Now I ask everyone about sex, and so I would bet if we broke that down into decades, 60 to 70, 70, 80, 80 to 90, and so forth, that we might see little higher levels in those younger elderly women. But overall, I think that's a fair number. My oldest sexually active patient that is having penetrative intercourse in my practice is 93 years old, and her partner is 90 and still able to maintain an erection. So I think that's absolutely fantastic. So don't be surprised when your patient is sexually active, and please don't assume that they are not. Both Stan and I have this slide because it's ever so important in discussing how we go about approaching hypoactive sexual desire and other sexual problems in women. It is an integral part of mixing everyone together so that we're a team taking care of the patient. Now, as a physician, I am very much in charge of the biology of the sexual response, and that's the physical health. Does she have a hip replacement? Does she have a blood clotting disorder? Does she have some kind of physical ailment that's prohibiting her from enjoying sex? But also the endocrine function. Is she deficient in her hormones now that she's reached menopause? Does she have thyroid disorder? Does she have insomnia? And then the neurobiology, which we'll get into a little bit more. So I really like to focus on that part. But as a gynecologist, I'll tell you that it seems as though a third of gynecology is actually psychiatry, because mood disorders are prominent in women. Statistically, 70% of women will experience some type of mood disorder throughout their lifetime. And so when we move into the psychology aspect, while this is not my expertise to continue on daily counseling, I can certainly address and identify problems with anxiety and depression, but also in their partners who have performance anxiety. The sociocultural aspect can often be seen, and we almost know now who to key in on based on our experience. But the upbringing and the anticipation of what good sex is in a particular culture varies widely. And so understanding how the patient was taught about sex and who influenced her ideas about sex will be very helpful. And sometimes we have to back away and really help the patient understand why she may have received that messaging as a young girl. But it does influence their behavior for a lifetime. So I caution parents all the time to be very careful about the messaging in young women because it can influence their healthy sexual behavior later in life. The interpersonal relationship, of course, is key. I make many funny comments during my lectures about the constant bickering in marriage and the fact that you're almost always annoyed with each other after 30 years of marriage. So the quality of the current relationship is key. When I see patients, just the willingness of two people to discuss their sexual concerns with me and engage in a conversation to make it better really helps play a role. So while you see Dr. Althoff is one of the authors of this model, I will tell you that this is a key slide, and it says that the approach to the female sexual response is a host of folks that work together to make this patient better. Some patients get annoyed when their primary doctor says, oh, don't worry, it's all in your head. While I think my colleague said that just to get the patient to go away, I will tell you that when the patient says that, I say, you know what, they're actually right. They might not know why they're right, but in fact they're right. So most activity in sexual function for women is above the neck. So there's a host of neurotransmitters and neurohormones that are responsible for our activity, and there are several regions of the brain that are involved. So you can see in regards to normal transmitters, dopamine and norepinephrine are key, and serotonin also plays a role, which we should caution our patients about, as well as the other physicians. When we jump over to the hormones, no surprise that estrogen and testosterone play a role, and there's lots of data discussing that. Oxytocin is a new target in biology that will be discussed. And then the endogenous opioids is really a problem across this country in our patients taking pain pills. And so I try and motivate them to lessen their opioid use to help with better sexual function. And then pheromones are always interesting because this is how our pets get to know each other. The areas of the brain involved are vast, as you can see, the basal ganglia, the amygdala, the insular cortex, the hypothalamus and the hippocampal region, the ventral tegmental area and pituitary and so forth. So suffice it to say that when we are studying the brain, we're fascinated at some of the findings in those with sexual problems and sexual desire issues. So looking specifically at the neurotransmitters, excitatory or turning on for sex is dopamine and norepinephrine. On the hormone side, estrogen and testosterone are key. And so this is a conversation, again, that I have with physicians to say, really address both estrogen deficiency and testosterone deficiency in your patients and understand that that may play a role in decreased desire. On the inhibitory side, serotonin. So many of our patients are on SSRIs to help with mood disorders. But perhaps we should be selecting our medications a little differently based on the inhibitory issues here. Now, mind you, if the patient wasn't having sex because she was depressed, and now we treat her with an SSRI and she's better, then the serotonin is not going to be an issue for that patient. Prolactin is the milk hormone that makes our breast milk come in, so one of many reasons why a lactating woman doesn't have desire. Her prolactin is high, which is inhibitory. Her estrogen is low, leading to vaginal dryness. And the fact that she's probably significantly sleep deprived plays a huge role. When we look at arousal, dopamine and norepinephrine right there again as number 1 and 2, testosterone and estrogen also included here, but we add nitric oxide and acetylcholine into the arousal phase. Again, inhibitory, serotonin, prolactin. So again, I try and remind docs of things that may be influencing their patients. Sadly, patients really don't take a proactive role in discussing their sex for a variety of reasons. This slide is from the PRESIDE study, which is the prevalence of female sexual problems associated with distress and determinants of treatment seeking. Now you understand why we just call it PRESIDE. But only about 35% of the patients will actually discuss their sexual problems with their doctor. Thankfully, most of them do choose their gynecologist, so I really try and cater to this audience and help them understand how to take care of their patients. Informal discussion is 42%. Who's that? That's their friends. Of course, they know their friends know more about sex than their doctor. Maybe sometimes that's true, Unfortunately, their peers often have the exact same problems, like painful sex due to vaginal atrophy in menopause. So I think that getting an okay, I have that too, makes the problem not better, and in fact, nobody asks. 15% never ask, and 9% use books and other methods. So again, let's discuss this with our patients. Open up the dialogue, even if you don't know what to do. This list of drugs just tells you there's a whole bunch of medications that our patients come to us on that are used every day that influence a patient's sexual issues. And so it is our job as the physician to review each of these individually with the patient, and I try and find a timeline of when they started the med and when their sexual problems began, because it's not the cause all the time, but it's certainly somewhere to start looking. Every physician should understand that a dry vagina is not desirable. It is never okay to have a dry vagina. While the patients are using over-the-counter meds, the scientific evidence is limited in many. And as you know, there are water-based lubricants, which most of our patients have access to. But in the menopause, the skin is so dry that they rapidly disappear and, in fact, sometimes get gummy and sticky and are actually not helpful in sexual intercourse. They need to be reapplied often, but can play a role. I prefer silicone lubricants in the menopausal ladies because it stays on the skin a little longer. Don't forget to mention that things like coconut oil, olive oil, or vegetable oil that are handy in your kitchen are also very good for lubricants and making the skin feel good with intercourse, especially if you're having sex in the kitchen. Regarding vaginal moisturizers, these are longer acting and they're inserted into the vagina and generally last for 3 to 4 days. But again, do nothing for the elasticity of the skin. So really, if we're trying to change the elasticity of the skin, we really need to give a little bit of topical estradiol in some form or perhaps an oral non-estrogen product to manage this issue. Never overpromise the amount of time that it's going to take. So we're most excited to tell our patients that, and our physicians actually, that there's a new product available. I was very excited in August when we received approval and the product became available in October. And so I'm now lecturing to docs to tell them a little bit about Flibanserin and how it works. So the action that Flibanserin has is twofold. It's a serotonin 1A receptor agonist or stimulator and a serotonin 2A antagonist. And so that is unique amongst other products that are out there, and perhaps it's this synergistic action that potentiates the inhibition of glutamate release from the axon terminals in the prefrontal pyramidal neurons. And that is one of the thoughts of how this may be in control of desire and arousal. We know that dopamine guides attention, and that is increased, and norepinephrine guides alertness, and that too is one of the transmitters that is increased. And serotonin creates inhibition, and thankfully it appears that that is also decreased in these pathways. So very exciting new product. As always, physicians are worried about safety, so I'm constantly answering questions about how do I prescribe it and is it safe. There are well-characterized safety profiles with extensive exposure data for this product. So I'm excited to present to these docs something that will open the discussion with the patients, because now they feel like they have something to discuss with their premenopausal women with acquired and generalized hypoactive sexual desire disorder. So if anything, it begins the conversation and gets the physician more interested in their patient's sexual health, and the patient will be forever grateful.